Then we have gross appearance. Long cylindrical part of the nervous system, the spinal vertebral canal. Many things you will be knowing. If you are knowing many things, we can skip them to be quick. Okay. Then it is roughly 45 centimeter long, upper 2/3 of the vertebral column. Remember, in adults, it is only occupying the upper 2/3 of the vertebral column. Don't think the whole of the vertebral column is there. So it is only 2/3 of or the upper. Start as medulla oblongata. After the continuation at the level of foramen magnum. So this is the level of start. Finish. L1 vertebra in adults and L3 vertebra in young children. I will explain you in a minute why so. Covered by 3 meninges. This is spinal cord. This spinal cord. So here we have 3 coverings. One, another one, another one. Dura mater. The outermost is the dura mater. The middle, arachnoid mater. The innermost, the pia mater. The pia mater is quite adherent. It's quite close to the nervous tissue, even in the brain, even in here. So, if I try to remove some pia mater, it may damage the nervous tissue. So, one has to be careful. Initially, they used to say there is a subpial space, but now the new books are saying no, there is no subpial space. Then we have CSF in the subarachnoid space. I will give you pictures now in a minute. Conus medullaris, you should know when you are saying anything of spinal cord, you should know about conus medullaris, filum terminale and cauda equina. So what is conus medullaris? Here is the start point of spinal cord. This is the level of foramen magnum and here is the medulla oblongata, pons, medulla oblongata and then is the start of the spinal cord. Finishing is here. How it is finishing? It is finishing like, not abruptly, not finishing like, no, it makes a cone. It makes a cone like this. See here, this is the cone. So it makes a cone to finish itself. This is known as conus medullaris. Anything medullaris or medullaris is related to the cord. Okay. Then we have cauda equina. What is cauda equina? The bundle of spinal nerves and spinal nerve rootlets of L2 and S5. And coccygeal nerve that arise from the lumbar enlargement and conus medullaris. So here is actually the finishing process. This is the upper 2/3 of the vertebral canal only. The remaining part is filled with some part of conus medullaris. Then we have multiple small branches and they give you a shape like this. Cauda equina. This is a real image of the spinal cord. There are multiple like cauda equina with one central part. This is known as filum terminale. What is filum terminale? Filum terminale, this is spinal cord. Okay. Now this is conus medullaris. Okay. So you come down. The pia mater is covering all and it's very close to it. It does not finish here. It will make a small string like thread like structure and go down. This is the one, filum terminalis or filum terminale. Here also again, see here, the spinal cord, the conus, the filum terminale, cauda equina. So all the things are visible in one picture. Coverings and spaces. I draw this picture, it may not be very appealing to you, very attractive, but it will give you more learning. How? Please adjust it. Thank you. Okay. Now see this picture first. Here we have brain, then we have a spinal cord and the spinal cord is ending here. In the form of cone, the conus medullaris. With me?
Yes.
Good. So this green line is the cord, so here is the cord. The green line is the cord. I am showing you both the transections, like this, horizontal and vertical both. Now, the spinal cord is finishing here at the level of L1 in adults, I told you. So the lowermost part is L1 in adults. Then we have L2, 3, 4, 5, S1, S2. It has 3 coverings now. The outermost is dura mater. See, this outer green line is dura mater. Outer green line is dura mater. It is just inside the bone of the vertebra, the ring, the vertebral canal. So here it is just inside, it's the dura mater. I make more gaps here, just to understand. Don't think the gaps are so big. Okay, the gaps are, the layers are close to each other. So the first one is dura mater. Here you have dura mater. Then you have arachnoid matter. Then you have arachnoid matter. Then you have pia mater. Red one, the pia mater. I told you pia mater will make a phylum terminal, and here is the phylum terminal, which does not contain any nervous tissue after L1 or L3 in children, but it connects itself to coccyx 1. So L1, all 4, 5 lumbar vertebra, then sacral vertebra or sacrum bone, then it will reach the coccyx 1. Don't think it's cervical 1, huh? It's coccyx 1. So here we have coccyx 1. The two other layers, they even don't finish with the cord. They are finishing at the level of S2. So the best place to get a sample of CSF is not here. I'm going to damage the cord. Is of course here after L1 in adults or L3 after L3 in children, because I have an extra space to have CSF sample, and this is the best place for it. Number one. Number two, see the spaces related to it. Dura mater, arachnoid mater, pia mater. Outer to dura, we have epidura, epidural space. These are the contents: loose irregular tissue, some fat. I will have another good slide to show you later on. Just give you some idea. Then we have subdural space between the dura and arachnoid. Dura, subdural space. Small capillary space, nothing much inside. Arachnoid matter, the blue one here. Subarachnoid space is the big space. It contains cerebrospinal fluid, CSF we call it. Then we have pia mater, and after pia mater we have immediately the nervous tissue which is connected to it. This clear? So conus medullaris finishing L1. Dura mater, arachnoid mater, both of them finishing S2. Conus medullaris finishing coccygeal 1. Going down and fixing itself to the coccygeal 1. Khalas?
Yes, thank you.
Okay. Why we have the difference between, I told you the upper 2/3 is only filled with the cord. The remaining is with the cauda equina. Why? What happens in a fetal life or just after birth, we have the same length of the bony vertebral canal and the spinal cord. We have the same length. Now, there is a race going on. The bony growth is rapid. So, if the bony growth, both of them, they are like at the same level to start with. The bony growth is more. I don't say it is not growing. It is also growing, but the bony growth is rapid. So that is the reason we have a gap. Now you understand? So in childhood, it is roughly L1, 2, 3. In adults, it is L1 usually, because still the growth is happening. In children, it's just a small growth at this level only. So this is the reason. Another thing important is here. See, this was S1 initially in the childhood or in the janine. Now, once the rapid growth of bone will take the nerve with itself. So this is going to make a lot of nerves, and that is going to make your cauda equina. Clear now? Same is happening here. But now the problem is, L1 was here, this was the coccyx, the final level. Now it is here, and still now it is here. And it is not facing the same segment of the spinal cord. So we should have some formula to correct it, how to find, is this really related to this or it is related here or here. So we should have a formula. This is known as spinal segments with vertebral levels. I cannot find my spinal levels, but I can find my vertebra. So with making some formula with the vertebra, I can guess the spinal level. Are you with me?
Yes.
Getting this point? Okay. The part of the spinal cord to which any pair of spinal nerves is attached is called a spinal segment. So this is a spinal segment with one nerve here, one nerve here. This is a spinal segment. We have 31 spinal segments with spinal nerves. You know it. The spinal cord segments are not in line, not associated truly with the corresponding vertebra. And the reason you know is developmental reason, I told you just now. Difference increases as we move down. So here at C1, both of them, they are of course the same. Even C2, C3, there is some gap, some gap, some gap, some gap. Until I reach L1, here is L1 and the vertebral level is L1 and the spinal cord is finished. So this difference has to be helped out how? For clinically and other purposes, we do what? In the cervical region, add one vertebra, add number 1. For example, to the number of vertebra to get the spinal segment, for example, C5 vertebra lies opposite C6 vertebra, so we add 1 here and we guess C6. I can find C5 vertebra, I can find C7 vertebra. So, if I find C7, what is the spinal segment?
C8.
C8 most probably. Okay, so this is the difference I am trying to explain. In the upper thoracic, how many thoracic we have? 12. So 6 is the border. So first 6 we add 2, 7, 8, 9 we add 3. Good. So T10 is facing L1 or L2 like this. For example, T4 vertebra is facing T6, I add 2. Then in lower I add 3. T9 is facing T12. So the same rule applies for the whole cord. Good. Why this is important? If a person has an injury on the spinal cord, I cannot guess the spinal segment. I can only see the vertebral level. So from vertebral level, I should use this formula, this formula, this formula for upper part, cervical, thoracic and lower to find the. For example, this patient has a trauma here. When I examined the spinal cord, it was T4. What is the segment?
T6.
Yes. This is what I am just trying to explain you all this. So add 2, it is at the level of T6. If the trauma is here, think of
3.
yeah.
L4.
So you have to be match. The matching is not there. So you have to have this formula to find which spinal segment is damaged. Am I clear for this?
Yes.
Surely?
Yes.
Great. Vertebral canal or foramen, you know this is the vertebral foramen. And if I keep all the foramens together, it will give you a canal for the spinal cord. Not only the spinal cord, what is inside this? Allah subhanahu wa ta'ala has packed so nicely the spinal cord itself. 3 meninges, then a CSF, then the blood supply, then the venous drainage, and then the branches. So it is the area where we have all this. This is known as vertebral canal. You know this picture now very easily.
Yes.
There is no problem. Now there are other structures related to this phylum terminal. See this pia mater, you will find structures like this in the whole length of the cord. This is known as ligamentum denticulatum or denticulate ligament. What is this? Spinal cord and brain are jelly-like structures. They are not hard like this. They are jelly-like structures. So, to hold the jelly in a proper position, the pia mater, which is very close to the cord, is adhered, is fixed like nails from pia to the dura at all the spaces. So, this is, and if you see the hole, it will appear you like teeth of the shark. So, ligamentum denticulatum like teeth. Attached on each side, pia structure, dura, teeth-like appearance, they are 21 in numbers. Provide stability to the spinal cord against the motion within the vertebral column. Clear now? So ligamentum denticulatum is a supporting part for spinal cord. The origin is from pia mater. It is a structure of pia mater. Similarly, we have two other structures. Linea splendens. Now I'm starting a bit of French. Okay? This is the real neurology. So linea splendens. Where is linea splendens? Here. In this part. Anterior part of the spinal cord. The pia mater, again it's made up of pia mater, forms linea splendens which extend along the whole length of the cord in front of the anterior median fissure. This is anterior median fissure. Here is the spinal cord. So here is the anterior median fissure. So all this thick pia mater is here just to hold all these processes, the splendens, the ligamentum denticulatum, and the third one is here. This is ligamentum denticulatum, and another one is here, subarachnoid septum. So all these three are made up of pia mater. They are in close approximation of the spinal cord, and they are there to hold the structure in a proper position and allow some movements, since it is a jelly-like structure, soft structure. This picture makes you easy understanding. We have dura mater, then we have arachnoid mater, then we have pia mater. There are spaces related. So this is one layer of meninges, space above, space down. Arachnoid mater, space above, space down. Pia to the nervous tissue is adherent. So dura mater, outer to dura mater is extradural space or epidural space. What is in the epidural space? I'll write it here. Loose areolar tissue, some fat like semi-liquid, then spinal arteries, and internal vertebral venous plexus is here. The second space after dura is subdural space. These are the contents. Capillary space, hardly potential muscle space filled with some serous fluid just to allow the movements of the cord. Arachnoid matter, this is the thickest layer. Then we have arachnoid matter, which is glistening, shiny, membrane-like structure, and we have a big subarachnoid space. In this big subarachnoid space, the biggest item is CSF. Lumbar cisterna is the lowermost dilatation of the spinal cord in the central canal. It can happen. It is wider than subarachnoid space of the brain, cerebral circle, spinal blood vessels and spinal nerves. After subarachnoid space, we have pia mater. So pia mater is adherent to the spinal cord, and it has small blood vessels, branches, and then we reach the nervous tissue. When I am trying to get a sample of CSF, my needle is coming from here, and then I will have a sample, and it should be below L1, L2 in adults and L3 for children. In the children, because I don't want to damage the spinal cord. I need only the fluid sample. Lumbar cisterna. What is lumbar cisterna? Is a subarachnoid space in the lower lumbar spine. This empty space is known as lumbar cisterna. Once we finish the spinal cord, this is known as lumbar cisterna. Of course, it contains a filum terminalis, but it is in the fluid. It is surrounded by a fluid. So if there is a needle or something, don't think it is pierced. It is just displaced by the needle in the fluid, because since it is in the fluid. So this is dilated part. This is known as lumbar cisterna. Cisterna means a dilated cavity containing some fluid. Like here we have fourth ventricle, there is a cisterna, like other things. We'll do it. This is the picture showing you all the three layers. See this illustration first. You will find the spinal cord. You will find the outermost covering, dura mater. After dura, you have pink arachnoid. After arachnoid, you have subarachnoid space, and this red is pia. The red is not spinal cord. The red is pia. The spinal cord outer should be white because here is the white matter. This is the real image of the spinal cord during the surgery. They have removed, thus displaced the dura mater. You can see shiny, glistening arachnoid matter, and if I just puncture it, CSF will gush out. So this is the space for subarachnoid space which contains CSF. Are you with me?
Yes.
Good. Here is the UL position. We take CSF sample. So I should be, how to guess this is like the same L2, 3 level. Try to find the iliac bone. The margin of the iliac bone, draw an imaginary line and then enter. This is a landmark for. We have a CSF clinical skill as well. I hope if the specimen is there, even we can find some fluid. Okay, now the spinal cord is not straight like this. It has some, they known as thickening or dilatations. They are especially seen in two places. Number one, cervical enlargement, lumbar enlargement. Cervical is C5T1. C5, 6, 7, 8, T1. And whenever you remember this sequence, C5, 6, 7, 8, T1, you remember brachial plexus. So, there are more nerve cells here to give you more branches for brachial plexus. Similarly, you have a lot of thickening here, L1 to S2 segments, lumbar and sacral plexus. There are certain variations in some books, but they say this can be one segment before, one segment down, one segment before, one segment down. But most of the people, most of the authors, they agree on these levels. So these two levels are important to remember. So these are brachial for brachial plexus, and this is for lumbar plexus. This is known as cervical enlargement or thickening, and this is known as lumbar enlargement or the thickening. Are you with me?
Yes.
Good. Features of spinal cord. Outer and inner both, I will do it in this slide. Whenever you are given a sample of or a model of spinal cord, try to find where is anterior, where is posterior. So, the best thing to find anterior is anterior median fissure. So we have a gap in front. Plus, if you don't even find this in any model, any picture, try to find the posterior root has a ganglion. Spinal root ganglion, posterior root ganglion, dorsal root ganglion. Any name. So dorsal root ganglion should be here. So this point, always keep it here to focus you the other structures. So this is now anterior part, this is now posterior part. Here we have H-shaped gray matter. The gray matter is further divided into anterior horn, posterior horn. Similarly, we have white matter divided into three parts: anterior, lateral, and posterior white column or white horn or white matter. What is the limit for anterior? This nerve root, anterior nerve. So from midline till this level is the anterior. From this nerve root to this posterior nerve root, we have lateral. And from here to the posterior median sulcus, we have posterior. Again, try to find out a gap, anterior median fissure. We don't have a gap on the back, posterior median sulcus. We only have a depression. We have a secondary septum or depression also. But this gap is obvious, so you should be able to see, because most of the time in exams, if like this, students are confused. So don't be confused. Try to find two structures. Number one, anterior medial fissure, a broad anterior horn gray matter, and a posterior root ganglion with a posterior. Are you with me? Good. Here we have a sulcus or depression. For what? The exit of anterior branch of the spinal nerve. Here also we have a depression for the posterior root, and the posterior root of course has a ganglion here and a ganglion. Am I clear? How many cervical nerves? We have 31 pairs. We have 7 cervical vertebra, but we have 8 cervical nerves. Okay. Then we have thoracic 12, 5 lumbar, 5 sacral, 1 coccygeal. They make 31 pairs. Related to the plexus, cervical plexus C1 to C4. This red, I write it red because there is variation in many books. But this is the most authentic levels. So, brachial plexus, then we have lumbar, and then we have sacral, lumbosacral plexus. Why we have 8 instead of 7? Here is the reason. There are 7 cervical vertebra but 8 cervical nerves. Because the cervical C1 comes out rostral or in front of the C1, and C8 goes behind the 7th vertebra. So that is the reason we have 7 cervical vertebra but we have 8 cervical nerves. You know this formation from the even first year. We have the gray horn of spinal cord. Here is anterior root, here is posterior root. Now, Anterior root, posterior root. How to find this is posterior root? Posterior root has a ganglion. Now, once both the roots they emerge out of the intervertebral foramen, it will go and it will make a nerve, spinal nerve. Don't think spinal nerve is a long structure. Only for a small part they will merge together, anterior and posterior root. It will make a nerve, and then soon the nerve will divide into. So spinal nerve, each spinal nerve is attached to the spinal cord by two roots, anterior and posterior. Anterior is efferent or motor fibers, posterior is afferent, also known, and it contains sensory fibers. Plus it contains sensory root ganglion. What is in the ganglion? The cell bodies of the posterior fibers are located in the posterior root ganglion. So here we have cell bodies and here we have axons. Okay? Now, the next is the anterior root, posterior root with dorsal root ganglion, they will make one nerve. So the spinal nerve is only this length. Soon after formation, it will divide into anterior branch, ramus, anterior ramus, posterior ramus, or ventral ramus or dorsal ramus. This is motor, this is sensory, here is the mixing. So now we have sensory motor here both, sensory motor here both. Plus, we have a sympathetic ganglion here. Both the sides, sympathetic ganglion. So the sympathetic ganglion now giving you sympathetic fibers even inside. So you will have three types of fibers: sensory, motor and sympathetic. Sensory is simple for sensation. Motor is for activity. Why sympathetic? Because once this is going into the muscles, then the blood vessels, near to the blood vessels, it has to be supplying the sympathetic action as well. Or the autonomic nervous system should have the access. So this is the reason. This spinal nerve get out from where? This part of vertebra. This is half, this is known as intervertebral foramen. Half is contributed, half is contributed by the body and the structure of this vertebra. Half is contributed by the lower vertebra, and this is the point for the exit of the spine. And you know it. You have seen many in the vertebral canal and vertebral column. I have shown you. After that, we have anterior ramus. This anterior ramus. This posterior ramus or the branch. Anterior ramus is larger, continues anteriorly and supplies the muscle and skin over the anterior lateral part wall of the body and limbs. So here is my spinal cord, here is the anterior nerve coming. So it is supplying my, of course, the neck muscle in the cervical region, the intercostal muscles here in the thoracic region, abdominal muscles and other structures in the lower abdomen. Then, the posterior ramus is small and supplies the skin and muscles on the back. See this picture? This will make your life more easy. See this picture. This is spinal cord, this is anterior root, this is posterior root. After that, it makes a nerve. The nerve divides into anterior branch or anterior ramus and posterior ramus. See the muscles of back and vertebral column being supplied by the posterior, and the anterior abdominal wall, including the intercostals and others as we go down, are supplied by this anterior branch. Here it can have some cutaneous branches as well for sensation. This is another picture showing you all the components of a spinal nerve. Anterior root, posterior root, anterior root, posterior root, with posterior root ganglion. You can see grey matter, white matter, anterior root, posterior root. This is the formation of the spinal nerve. And this is the level to get exit out of the intervertebral foramen. Now, this is the anterior branch, anterior division, anterior ramus. Here is the posterior ramus. Here is dorsal root ganglion. Here is sympathetic ganglion. And you know sympathetic ganglion will make a sympathetic chain. And until the chain is finished in the lumbar region, in the center midline we have a big ganglion known as one real. Who will tell me the name of the ganglion? Ganglion impar. So sympathetic chain will finish here in the lumbar region with on one ganglion in the center, ganglion impar. Good? Understanding?
Yes.
I forget to tell you one thing here. I must go back. Here in this picture. See, the gray matter is communicating with each other. So this communication is anterior, this communication is posterior. Here we have a central canal. Central canal also contains CSF. How it will reach here, you will do with the CSF circulation, you will understand. Here we have anterior gray commissure yani connection. Posterior gray commissure. Again, anterior horn, posterior horn. Anterior gray commissure, posterior gray commissure, central canal. Then we have anterior white column, lateral white column, posterior white column. Always remember two things. The dilatation or a big part in the anterior gray horn. Anterior median fissure is most important. Posterior root ganglion is to support you to find the location. Am I clear?
Yes.
Okay. Now, I have told you two horns. Anterior horn, posterior horn. In the sympathetic, all the thoracic, yani T1 to T12, plus L1, sometime L2 or L3. So T1, 2, 3, 4 until I reach T12, or by then L1, L2 and maximum L3 sometimes has a third segment. When I say third segment, it means like this. This is spinal cord, which I just told you. Here we have another horn. And this is known as sympathetic outflow or the lateral horn. It is a part of the gray matter. When I write in my slides very small font, this is an extra information. This is not your real objective, so you can just read it. So, this structure is present where T1 to T12 and L1, L2, L3 max. Not after that, not before that. This is known as lateral. And this is for sympathetic outflow. Gray matter nuclei. What is inside the gray matter? Gray matter is composed of the nerve cells, cell bodies. It contains many nuclei. Anterior horn, it contains many nuclei in the posterior horn. This will be done in very good details by Dr. Hindavi in histology. But just to give you an idea, gray matter has nuclei in the anterior and posterior gray matter like medial nucleus, central, lateral. And they have other name, nucleus in the posterior horn. White matter is for the passage of tracts. The neurons are crossing in the white column or the white matter. This is an important issue. Arterial supply of spinal cord. We have four sources. One anterior spinal artery is here. This is the cut part. Now I should know this is the anterior because I have a fissure here and I have a only sulcus here. So here I have anterior spinal artery 1. Here we have two spinal arteries, one here and of course the other is lying here. Okay, so we have two posterior cervical spinal arteries. Anterior spinal artery, two posterior spinal arteries. Then we have segmental arteries. I will explain to you now. And then we have a feeder, one single artery from aorta, direct branch from aorta. What are the four sources? Are you aware of this structure?
Yes.
Known as?
Circle of Willis.
Circle of Willis. Where it is located? Very good. Here is the circle of Willis. This is the spinal cord or the medulla oblongata, and here we have circle of Willis location like this. Here is the circle of Willis actually, and it has multiple branches. This is two vertebral arteries. So the anterior spinal artery is formed by the union of two arteries, each arising from the vertebral artery. One branch from here, one branch from here, it will make anterior spinal artery. Where it is? This is spinal cord. Here should be the anterior spinal artery. Good? Formed where? Under the brain, near the foramen magnum. So here is the anterior spinal artery. Am I clear?
Yes.
So this anterior spinal artery will go the whole length of anterior spinal cord here in front. So it is formed by the union of two arteries, each arising from vertebral artery inside the skull, near foramen magnum at the level, runs in the anterior median fissure and supplies 2/3 of the cord. If I cut the cord and see anterior 2/3, posterior 1/3, it looks strange that anterior is one artery, but it is bigger, so it is supplying the anterior 2/3, a larger area. And on the back we have two arteries, and combined they are supplying the small
Just
2/3 on the back. Then we have two posterior arteries, spinal arteries. One is located here, one here. What is the origin? Arise from the vertebral artery, either same from the vertebral artery, from this, or from this branch, posterior inferior cerebellum. So anterior spinal artery and posterior spinal arteries may be directly from here or dually from here. So this is the origin of posterior spinal arteries. There are two in number. Again, arising at the skull, foramen magnum, runs on the posterior posterolateral sulcus, reinforced by, so now here we have anterior spinal artery, here we have two posterior spinal arteries. They are helped or reinforced by this segmental arteries. From where they are entering? The same small foramen from where the spinal nerve gets out, the segmental artery gets in, intervertebral foramen. Reinforced by small segmentally arranged arteries from outside the vertebral canal, point of entry intervertebral foramen, anterior and posterior branches, they are known as radicular arteries, and anastomose on the surface to send branches to the surface of the grey and white matter. Clear now? Again, here we have anterior median fissure, we have one anterior spinal artery. Here we have another depression for posterior nerve, nearly that level we have two posterior arteries. The importance is the anterior artery supplies larger area in front, anterior 2/3. The two small will give to posterior 1/3 of the cord. Reinforced by segmental arteries. Segmental artery is coming from where? The segmental artery is basically coming in the neck region. They have deep cervical arteries, vertebral arteries, and ascending cervical arteries. So these arteries will give branches to the spinal cord on the sides, the reinforcement branches. In the thoracic region, with the help of intercostal arteries, will give this branch. In the lumbar region, lumbar arteries, sacral arteries. In this, we have a lot of variation. Okay, so variation is there. Feeder arteries. Up till now, you know anterior spinal 1, 2 posterior spinals, segmental. So 3 sources. The 4th source is here. Feeder artery. Great variation. It is a direct branch from aorta for spinal cord. It's a new information. Great anterior medullary artery. This is one name. On the name of the person, Adam Kivisis. So, great anterior medullary artery is Adam Kivisis from aorta. It has variations from left second lumbar vertebra or T12 or L4. So, here is the aorta. At this anterior level, this Adam Kivisis can be arranged. So, now you know 4 sources of blood supply. Anterior 1, 2 posterior spinals, 3 segmentals, and fourth branch from aorta, and the name is Adamkimesis. Am I clear? How they supply? And what is the clinical if supply is blocked? Artery of Adamkimesis lesion will produce paraplegia. Paraplegia means both the lower limbs are paralyzed or weak. Hemiplegia means half of this body, half of this body. Hemiplegia. Paraplegia means both of the lower legs. Because it supplies the lower third of the spinal cord. It's a big artery. Anterior spinal arteries, due to occlusion of or any other reason in the interruption of the flow, the anterior 2/3 of the cord will be suffering. Because this is the single artery, but it's supplying the big part of anterior 2/3 of the cord. So, below the level of lesion, there is loss of almost all motor and sensory functions. This is the effect of occlusion of anterior spinal artery. Posterior spinal artery, since they are two, so we are lucky, it's rare that both of them they are blocked. So one can be blocked either right or left, and we can have symptoms depending upon. Posterior spinal artery, due to occlusion or other reasons of interruption in the flow, unilateral, usually. Why? Because we have two arteries. And it's rare for both the arteries to be clogged until we have a very big systematic disorder. Isolated loss of vibration and proprioception is the effect when we have lesion in the posterior spinal artery and the block. So, first is anterior spinal artery from the vertebral artery and one branch. The second is two posterior spinal arteries, maybe from the vertebral artery or from the posterior inferior cerebellar, and they are lying posterior. Third, segmental arteries reaching into the cord with intervertebral foramen. The fourth is aortic, and here is the list of lesions. Am I clear?
Yes.
Are you going with smooth?
Yes, veins.
Okay, veins. How the vein is draining? Drain into 6 veins. Usually, the spinal cord has 3 anterior veins and 3 posterior veins, making total 6. Or sometimes there is variation, 4 in front and 2 on the back. So usually there are 6. Longitudinal veins arranged like this. Anterior and posterior intervertebral venous plexus in the epidural space. Communication, dural venous sinus and radicular veins. The radicular veins are in the center, in the middle, or in the surface of the cord, and the dural venous sinuses are in the brain. So, the problem with these veins is they have a venous valve-less connection. See here. Here we have a Batson venous plexus or Batson veins. It's a network of valveless veins that connects the deep pelvic vein and thoracic vein. Therefore, urinary bladder and prostate, they are drained by this to the intervertebral venous plexus. We have internal venous plexus, we have external venous plexus. Again, here is the spinal cord. In the epidural space, we have internal venous plexus. 3 veins here, 3 veins here. We also have this one. This venous plexus, internal, is very important since it is connected from urinary bladder and prostate with another plexus known as Batson, and that is the reason of communication of valvelessness. It gives you metastasis from rectum, prostate, and to the vertebral canal and the bones and even the brain. So that is the reason of metastasis from the lower organs into the brain. Understand?
Yes.
The trauma is very important. See here. This is an accident case with a trauma here. The spinal cord is damaged. Of course, the hip is damaged. Hip is fractured. Then, dermatomes. It's your SDL or probably seminar topic. So I will not go into details. That is the reason I hide it. Dermatome, just to give you a good definition. Dermatome or segmental innervation of the skin is derma skin and tome the thin segment. Definition is the area of the skin supplied by one spinal segment is called a dermatome. Good? And now, don't see this until I reach some lab slides. What is the time?
Which you want?
Finished.
Okay, lab in the lab.